Bonjour à toutes et à tous et bienvenue sur Nutrition&Sport&Health. Aujourd'hui, pour ce podcast un peu spécial, je suis accompagné de Mme Davila, diététicienne spécialisée dans la prise en charge nutritionnelle des maladies rénales. Et Mme Davila nous vient tout droit de Chicago, des États-Unis, donc ce podcast sera en anglais. N'oubliez pas que pour me soutenir, vous pouvez vous abonner à la chaîne, liker et partager ce podcast. Et quant à moi, je vous souhaite un bon visionnage. Hi, Madame Davila. Thanks to be
Hello.
here with me in my podcast. I'm really glad to hear from you. So maybe you could introduce yourself and talk to us about your background in clinical renal care, please.
Sure. Well, first of all, it's a pleasure to meet you, Arthur. And my name is Anita Davila. I am originally from Mexico, but I've been living in the US for the past 23 years or so, or 20 years. I forget. Um, I guess I became a dietitian not too long ago, actually, even though I did my undergraduate. And I finished that in 2015. I still had small children and at that time, and so uh, I didn't become a dietitian then. I don't know if you're familiar with the process in the US, but you needed an undergraduate degree, and then you needed an internship, and then you could pass the test and become an RD or a dietitian, a registered dietitian. So I didn't do that. I didn't begin that until 2019. I did my clinical training at a hospital here in the Chicago area. And then part of my internship was impacted by COVID, facilities closed and things like that. So that took a while. And I finished that 2022. I I took a few months to study for the dietitian test, and I passed that last July. Well, not this July, but the 2022. And so, yeah, I've been a dietitian for a little over a year. I started working at a big acute hospital here in the Chicago area, in what we call the Illinois Medical District. And it was a great place to get started. I learned a lot. I was doing, just like the inpatient hospital floors, a little bit of subacute rehab, nutrition, and then since December though, I started working with the dialysis patients. So the outpatient dialysis center, hemodialysis center, and then also the clinic that handles the patients who have peritoneal dialysis, who do it at home, but come to the clinic a couple of times a month to visit with the doctors. So I've been doing that since December, and just recently, about a month ago, I started also, well, I switched hospitals, but I started working with patients who don't yet have end-stage renal disease and don't yet need dialysis. So they are at different stages of chronic kidney disease. So yeah, like I said, it's been about a month that I started seeing those patients as well. Mhm.
So what do you do as a clinical dietitian specialized in renal care?
Yeah, so um, basically, basically what I do is I give education, right? I give them a lot of nutrition education based on their diet, the diet restrictions. As you know, typically the renal diet or the diet, for people with chronic kidney disease, it's going to be very specific in terms of certain minerals, right, and certain things. So I always teach patients that it's kind of like four things they need to always keep in mind when it comes to their diet in terms of the kidney disease. So, we recommend them a low phosphorus diet, a low potassium diet, a low sodium diet, and then depending on if they are And stay if they're chronic kidney disease, but they are not yet on dialysis, then we recommend the low protein diet. And then once they get to the point where they need renal replacement therapy, whether that is hemodialysis or peritoneal dialysis, then that switches, and then we recommend, the higher protein. So basically, I spent my day teaching these concepts to the patients, whether when they come in to get their lab drawn, or when they come in to see the doctor, or if they're having dialysis, they're sitting on a chair getting their treatment done. I stop by and I see them then. I meet with every patient at least once a month. Some patients need a little bit more education, or they just want to chat with me for another time. I do also do things by phone, so sometimes I'm calling patients to give them the information in case I didn't meet them in person at the clinic for whatever reason. And then for patients who have chronic kidney disease who are not yet on dialysis, they kind of come and go. So I have those patients, like I said, they kind of come and go. There's different doctors who refer to me, whether it's because they're new to being diagnosed with chronic kidney disease, or some of those patients also are referred to me because they're just being told that they're reaching a point where they're going to need renal replacement therapy at some point. So that most of my day is, when I'm at that clinic, it's spent talking to those patients. And then I get, random consults like kidney stones or something like that, but that's minimal.
So, in your point of view, what are the most challenging part of your job?
There are a couple of things, I guess. It's challenging sometimes when, for example, at the clinic, I'm being scheduled to see patients for like 20 minutes at a time. And that I don't think that's like enough time for me to thoroughly explain to them, especially those patients who have not had any nutrition education before related to their kidney disease. And you're trying to explain to them all the different things with the diet, the potassium, the phosphorus, the this and that. And some people come to me and they're like, what is potassium? Like they have no clue. Like we're just throwing words at them. And so it's really challenging to be able to provide a thorough education when, in 20 minutes or less. But that tends to be the situation, with all healthcare, I guess, because even doctors, right? They have like 15 minutes to talk to a patient, and that's often not enough time to thoroughly, make sure that they understand the concepts and stuff. So I guess that's probably the most difficult. And plus, I'm chatty and I can talk for a long time. So, that's a difficult thing when you're only given a little bit of time with each patient. Another thing, well, I feel like sometimes they feel a little helpless. They're a little bit discouraged with everything going on with their health. And then here I am telling them, don't eat this or don't eat that or something like that. So a lot of it is, the challenge is to help the patient feel a little bit encouraged, that they are empowered. Get them to feel a little bit more empowered to be able to make the changes that they need to do and not feel so discouraged.
And in your opinion, what are the most difficult part of a diet for patients with renal disease?
Well, I think for our patient population, I'm in Chicago, where, it's a big city. We have a lot of minority patients. Also a lot of patients who don't have insurance, they are low income. low education sometimes, and just they don't have the resources sometimes, or they don't feel empowered to to make their own meals or something like that, or just their situation doesn't allow them to, or they live in a food desert, you know. So I think the biggest challenge for some of these patients is um being able to cook a healthy meal, and eat some vegetables, and cook a piece of meat, and just like creating those healthy meals that for some of us is just like natural, right? Like you cook some protein, you cook some vegetables, you have a little bit of starch. It's like it comes natural to us. But for some of these patients, they might be working long hours. Like I said, they might live in a food desert, or they might be just challenged, or they might have a disability and they don't have anyone to help them cook. So what do? They typically go and eat, convenience foods, the hot dog stand, the hamburger stand, the convenience store, and chips and Coke, and just like all the junk food, right? Just because that's available to them, that's easy, it's usually cheap, you know, to buy these foods. And so what's going on with all these foods is that they typically have a lot of preservatives, frozen convenience foods have a lot of salt as well. So when I'm telling them to not consume a lot of phosphorus, for example, it's really challenging because phosphorus is like in every single food almost that you eat. But the problem with the phosphorus is, as you know, there's organic phosphorus, it's natural in the vegetables, in the meats of animals, and things like that. But then there's an inorganic phosphorus where it's just been added to the foods as a preservative most of the times, or just like an additive. And that's what causes more problems for our patients with when their kidneys are not functioning well, whether they have chronic kidney disease or they're already on dialysis. It just starts accumulating in the blood, and even the dialysis machines are not doing a great job to clear that out and filter that out as we would like. And so it's a challenging one. Like I have patients who might have a phosphorus level of 12 or 15, and it's like, what's happening here? But it's typically that just the foods available to them, or their skills in terms of preparing healthy meals and things like that. They lack those skills, or so I think that's probably what causes the most trouble, the phosphorus, but the salt as well. I mean, sodium is the same thing. You're eating processed foods, there's going to be a lot of sodium, in those foods most likely. So that tends to be a problem too.
And what simple diet advices could you give us for patients treated by dialysis? So some tips or stuff like that.
Mm-hmm. Tips for people who are already on dialysis?
Yes.
So I guess what changes is they need to eat enough protein. And sometimes that's what I have to really make a point to educate patients, is that they're coming from being followed by a doctor or a dietitian when they had chronic kidney disease. And they were constantly told, don't eat too much meat, because their requirements are 0.6 to 0.8 grams of protein per kilogram. So they're being told to restrict protein. Don't eat red meat. Don't eat all these, too much meat and stuff like that, protein. And so here they are now, where while they're on dialysis, as you know, whether it's peritoneal dialysis or hemodialysis, the process of that, it's pulling some protein from them. And so then you start seeing like albumin levels come down. And what the research tells us is that people who are on dialysis, there's a correlation between low albumin levels and mortality right down the road. So we want to prevent that. And so that's why I guess the biggest takeaway when you're on dialysis, and this is what I tell patients, is make sure you eat enough protein servings, to meet your needs. And it doesn't have to be all meat. There's also vegetable proteins. There's beans and chickpeas and tofu and other things like that you could get protein from. And in fact, there's a push for a little bit more plant-based diets and protein, and even in the renal space. So I guess the biggest tip is to make sure they include enough protein to meet their needs. And then the other tip I would say is reading food labels. Like that's really big. When you purchase something and you don't know, does it have too much potassium, sodium, phosphorus, whatever, the best thing to do is to read the food labels. And I don't know in Europe what exactly they need to have listed, but at least in the US, there's always going to be the sodium. It'll tell you. Now I think they're including potassium. Phosphorus is not something that it's required to be listed, but if you look at the ingredients list, and this is what I tell patients, try to look at the ingredients list. If you see a lot of ingredients that have the words phos, like phosphate, phosphoric, monophosphate, calcium phosphate, potassium phosphate, whatever phos, those PHOS letters that typically has, phosphorus, has phosphorus additives and things like that, preservatives, and that's what I tell them, to kind of stay away from those. Yeah, they're just foods like that where you have to play a little bit of like detective work and look in the ingredients and try to find that and see if there's a product that doesn't contain those additives. Is basically what I'm telling. So yeah, I think reading food labels is probably like a major one.
And in your unit, do you meet a lot of patients who suffer from denutrition in renal care services?
Who suffer from what? I'm sorry.
Malnutrition in renal
Oh,
care service.
yes, definitely. A lot of these patients have, they have a lot of issues. They've been in and out of the hospital sometimes for various reasons. Sometimes it's diabetes and things like that. They've had amputations, or they've had, heart disease, and they've had heart attacks, they have strokes. So some of our patients, they are quite frail, and they have definite signs of malnutrition. We typically assess them when they start dialysis. We do the nutrition focus physical exam. We check for muscle wasting. We check for edema and fat loss and things like that. And yeah, I would say maybe almost, I don't know, maybe a fourth of our patients may have had malnutrition at some point or currently, just because especially our older patients, I would say. Yeah.
And earlier you talked about ultra processed food. So do you think there are a link between the consumption of ultra processed food and renal disease?
That's a great question. I don't know if it's like a direct link, but I would say, at least for our patients, I would say the majority of them, they end up with renal disease because of their diabetes. That's the biggest one usually, at least for our population. They've had diabetes for years. They kind of never took care of, never kind of had it under control, and they have retinopathy. They have all these things that, diabetes tend to have, have microvascular damage and consequences. So typically it's the diabetes. A lot of the times is hypertension. And definitely I would think that ultra processed food and processed food is just like it's not good for hypertension and managing diabetes and things like that. So like I said, unfortunately, a lot of these patients, that's just what's available. And that's just what they're going to go for because they lack the time or the resources or the skills to be able to, kind of take control of your diet in a more healthy, way. So yeah, I think it plays a major role because of the role it plays with the lack of managing diabetes and hypertension and things like that.
So we know that there are link between the consumption of ultra-processed food and metabolic disease such as diabetes and obesity. So do you think we need to educate more patients about this concept?
Mm-hmm, mm-hmm. Yeah, and that's basically what I'm doing most of the time. I'm trying to empower them to know that, sometimes they have this conception or concept that eating healthy is really expensive and really difficult. And I know for a lot of people it might be, but I'm trying to always empower them like, you can do it, try to consume, fresh meats from the butcher, from the stores. I try to tell them about which stores in their neighborhoods have, the vegetables and the meats and things like that, and try to empower them to, you know, use the brown rice or the rice that is, instant, or do this or do that. Like try to make them feel like it's doable. It's a big part of what I do to try to make them feel empowered and encouraged to try their best and like make them understand that I'm not here to just tell them don't eat this, don't ever eat that, like blah blah. Like I'm not, at least that's not my counseling style. I like to make them feel more like I'm a partner in their journey, and I'm there to support them and cheer them on and show them that making little changes that are gonna last is sometimes better than trying to do like a major overhaul that might not be even be possible for them. So a lot of the times, even though I am discouraging them from, eating everything super processed and things like that, I'm also aware that some people just don't have the ability to make 10 million changes at a time. And so I kind of work with what they have, what they're available, and what they're willing to change, and try to empower them to make, small changes at a time and make them last and continue on, with improving their diet and things.
So do you want to talk to us about something else before we ending this podcast together?
Yeah, sure. Well, I was gonna say I did mention that next weekend I'll be in Denver, Colorado. So every year the Academy of Nutrition and Dietetics hosts this annual meeting where dietitians and international dietitians too visit, and there's workshops, there's professional development, things like that. There's lectures, and there's also the big expo. People have their booths, and there's food companies. There's like there's a lot, everything that has to do with nutrition or health and diet and things like that. It seems to be concentrated there for a few days. It begins on Saturday, on the 8th of October, and then it runs through Sunday, Monday, and ends on Tuesday, the 10th, I believe. So you're welcome to visit maybe this year or next year. I think next year will be in Minneapolis, I believe. So it's a different location every year. But yeah, sometimes I think there's even like 10,000 dietitians at a time sometimes there, or nutrition professionals. So students too. So yeah, it's fun, and I invite you for next time,
It will be a great thing to come next year, I think. So, Madame Davila, thank you for your time and your trust. So we will ending this podcast here. So thank you, and I'm looking forward to hear from you.
Yeah, thank you, Arthur, for the opportunity to talk to you about my role. And it was really a pleasure. And
Yes,
thank
me
you for
too.
reaching out.
So bye bye.
Bye.
Thank you for having listening this podcast till the end. So I will try to invite more international guests for the next podcast. So I would be glad if you subscribe to this channel and see you later. Bye bye.